and that sort of leads into his post surgical course. So overall, this is a
Hey,
timeline. Yes, sir.
sorry to interrupt you. When you had the two prosthetics, two prosthetics in between, you got Gore-Tex pericardium, and you've got now a Bellspan implant. Presumably, that's an envelope resection. Those things are all touching each other.
Yeah, so that actually gets into one of the discussion points towards the end, and that's a very good observation. Is that Gore-Tex was when he was open, not intimately near the esophagus, but I suspect that when everything was closed up, those two were fairly abutting each other.
What'd you put in between those?
So the pericardial fat pad, pedicle pericardial fat pad.
All right.
So this is a study timeline for overall what occurred with this patient. So appropriately got the informed consent, and then consistent with how we've isolated adipose stem cells for AMSCs before we did an abdominal wall fat biopsy. There was a little bit of logistical challenge here for us, and as well as I'm aware for BioStage, because what we usually do for our MSC studies that we use for other reconstructions like a bronchopleural fistula or Crohn's disease or something like that. We usually have it go here on site, but getting the fat that was human to Texas and back required a little bit of logistical hurdles with, say, the TSA and getting it packaged and out the door to where it needed to be for MSC isolation. So was shipped down to Texas on March 30th, got on an airplane, and CEI and MSCs were generated down there, and then they were shipped back up on May 3rd. So we got them the day before with the temp tails and the refrigeration box and et cetera. And then on the operation day on May 4th, we transported duplicate CEIs to the OR, just in case we needed a backup, as well as for further analysis by our BioStage colleagues. Immediately post-operatively, it went as a sort of expected for a large cardiothoracic operation. Was intubated, sedated on pressors for a day or two. Pressors were weaned off on day 1 or 2 for blood pressure support. Did fairly well post-operatively. Had some issues with being weaned from the vent. We had initially planned on really just taking his right lower lobe and not necessarily his right middle lobe, so had a little bit more of a complicated respiratory course than we would anticipate, but got a tracheostomy on the 17th and was subsequently decannulated after a slow ventilator wean on the 28th. And then after that words, he had issues with hydropneumothoraces and infections in the pleural space. Our suspicion was he may have had either esophageal perforation or contamination at that point in time, and or esophageal leak, and was subsequently worked up. I'll talk about the EGDs here and the sequence of treatment for that, but was discharged, readmitted. The CEI was ultimately removed on August 16th, so about similar to what the timeline would be for some of the pig studies. Then not replaced. He had a lot of issues with esophageal stent pain, and we had one period of time where we did not have an esophageal stent because it was so poorly tolerated. The remainder of this time, we did routine scheduled EGDs and stent changes. And then ultimately, he demised on the 20th of December, and I'll talk a little bit more about how that exactly occurred. So on the index day of operation, you can see very similar to what we did on pigs, as well as you guys have done on pigs, directly sewed the CEI to the esophagus there, and then stented across the lumen. We usually will sew the stent in place to prevent initial stent migration and dislodgement with absorbable suture. In this particular case, our GI endoscopists are very talented here, and so we used a more permanent suture, which they subsequently cut and exchanged. To go into a little bit more detail on the immediate post-operative period, there was no evidence initially or throughout the duration of his course of any immune reaction to the graft, allergy, or any other poor tolerance to the graft that we could detect clinically. or biochemically based on what assays we currently have. It's important safety data for us to be able to say that in humans, this appears to be early. There appears to be early good tolerance to this type of an implant. He had air leaks consistent with a lung resection afterwards. Subsequently, had the chest tubes removed, extubated to BiPAP support, developed AFib, which would also often occur after an operation of this type, and subsequently had issues with pneumonia, and that was part of the reason for the prolonged intubation as well as tracheostomy wean and subsequent decannulation. The first endoscopy was the stent removal. It's our practice to usually not leave these stents in for any time longer than 2 months. We've had bad experiences with stent erosions, and we've sort of seen that around 2 months appears to be the longest time that we're comfortable leaving a single stent indwelling without repositioning or redeploying a stent. It looks like you can see just past the CEI on the left-hand side of your screen in the lower left image. There's definitely tissue on the other side of that. And when we did put contrast down here, there was a small leak proximally from the CEI into the right pleural space, which was well controlled once another stent was redeployed in that area. But there was definitely tissue growth. When the CEI was peeled back slightly more, you could see similar to what we saw in the pigs, and I'll show that here in a minute. On the 16th, several months later, we removed the CEI as well as the stent. We were able to visualize a 1 centimeter fistulous tract into the right chest space, injected this with fibrin glue. And since he was so intolerant of esophageal stents, at this time we clinically elected not to redeploy. But you can see there's that beefy red tissue in that middle, the bottom middle image there. That's pretty consistent with what we had seen, based on your data and our data, for what that vascular conduit looks like.
When you say remove the CEI, you mean the scaffold?
I mean the scaffold, correct.
Yeah, thank you.
We call it CEI because it's now different than the scaffold because it has cells.
Yeah.
Right, but you didn't remove the grafts.
When you say graft, what do you?
Well, the
yeah, you are removing
tissue that grew.
You don't remove the tissue.
We do not remove the tissue which had grown over the scaffold.
The patient has tissue that grew as a result of the CEI procedure. That's a novel implant, and that was left in there.
Correct. Right. Correct. We did another sequence of EGDs, and it's what we would routinely do for this is we routinely drain these fistulous tracts internally. So what we do is we do a retrograde esophageal pigtail into the pleural space and drain these fistulas internally to the stomach and put a stent over it to provide a leak-proof barrier, or at least a leak mitigating barrier against further contamination. And we've had pretty good results. You can see that the 1 centimeter fistulous tract has now gotten quite a bit smaller. However, at this point in time, he did have a stricture down to 6 millimeters, and the fistula itself was no longer measurable in terms of size on endoscopy. And then we further stented again. And basically a rinse repeat was done on the subsequent EGDs, and the fistula was measured at this point in time on fluoroscopy to be about 5 millimeters in diameter. And again, the retrograde esophageal locking drain was put into place. And the image at the lower right part of the screen, you can see that the fistulous tract is off to the right of the screen there, but the remainder of the esophageal tissue appears to be completely epithelialized at this point in time, if morphologically a little bit abnormal, but it does appear to be completely epithelialized. And he had been eating throughout the duration of this course our pureed esophageal stent diet. On the 15th EGD, had another benign stenosis to 7 millimeters. The retrograde drain was well positioned, and we put a biliary stent across it after upsizing this to 10 millimeters via dilatations. And this appeared to be well tolerated and was able to go and tolerate his period diet through this stent as well. On November 13th of 2017, was admitted with fevers, bloodborne sepsis. Had an MRI of his head after he was found to have significant neurologic changes, and it was suggestive of CNS vascular infections and neurological abscesses. The family and elected to go with comfort cares, and patient subsequently passed away on the 20th of December. The preliminary cause of death before definitive autopsy was bacteremia with multiple ischemic strokes secondary to CNS infections. On pathology, what we showed was that there were multiple areas along the esophageal length which were completely epithelialized. The area where we think that the regeneration or regrowth had taken place was in the distal aspect here. We think that you can see this area here where there's a defect in the esophageal wall. That was intimately adhered to that graft in the IVC. So what we think happened was that that fat pad was probably not enough soft tissue buttress between the two prosthetic grafts, and that's ultimately why there was a fistulization there to the pleural space. However, you can see distal to that proximal fistula here, there's what appears to be pretty morphologically similar tissue to the proximal esophagus, and it appears that in cross-sectional and in longitudinal planes on H&E that there's basically full epithelialization of this area. Our IHC and other immunofluorescence staining that we've done also suggests the same, but that's a bit too much data for us to go through completely here and is a little bit unclear at this point in time. And we want to corroborate that a little bit closer with our pathological colleagues' findings and have them definitively say what they suggest. But it looks like that at least over the majority of surface area that was reconstructed, this esophageal muscular layer as well as epithelial layer recovered. So not that we can conclude much from one case, but showing that you can even generate these adipose-derived MSCs from elderly, debilitated, cachectic, cancer patients is and scale it to a clinical manufacturing grade is pretty important to show, especially if we're going to be doing this in an autologous manner in the future, and bring them up to scale and seed a graft with predictable characteristics. There's also the issues of how do you get the cells that are autologously sampled, adipose tissue, get them to another center that's going to be manufacturing the graft, and then getting that graft back to the facility which is going to be implanting it. There's logistical hurdles there that are not minor, as well as showing that there's no immediate graft reaction that we could tell. There's the possibility that they may, be allergic to their cells, which have been manipulated in a laboratory and seeded on a material that it's possible they could be allergic to, but that this graft immediately was well tolerated is important. And additionally, it appeared that over the majority of the surface area, the esophagus did appear to grow back, with the exception of that fistula, which had been managed fairly well before the IVC graft got infected, was what our ultimate suspicion is, but there's no way to know at this point in time for sure what exactly happened in terms of why the sepsis became neurologically lodged and generated abscesses. But that's our most likely scenario, is that the esophageal fistula contaminated the IVC graft and subsequently caused bloodborne sepsis and ultimately overwhelming infection and caused the patient and his family too much. But this guy was pretty tough and pretty savvy, and he went into it with eyes wide open, and he actually called the FDA several times to wonder why they hadn't approved his study yet. So he was a pretty savvy guy.
That's a great history. Actually, considering everything, I think they're a remarkably good result.
And Jonathan, Jim here, just one, if you don't mind, go ahead, please.
No.
Could you comment, sir, So, obviously under bypass, obviously, in an 11-hour, whatever long procedure within a graft that's, if you will, in heparinized pool, it's amazing in a number of ways for all.